subtotal esophagectomy with immediate esophageal reconstruction on the patient's nutritional status. Patients who need esophagectomy often experience weight loss before surgery, since their diet is initially severely limited by the underlying disease. Therefore, malnutrition is a frequent problem in this group of patients. Preoperative correction of patients' nutritional status is an important moment of rehabilitation. And in the postoperative period, it's necessary to maintain the nutritional status, because malnutrition and postoperative complications are two related factors that determine the speed of rehabilitation after surgery. Optimal approaches to preoperative nutritional support are described in the literature. The need for nutritional support after esophagectomy is not in doubt, but however, the type of postoperative feeding is still a controversial issue. There are two ways of nutritional support in the postoperative period: total parenteral nutrition and enteral nutrition. And after esophagectomy, it can be either oral by sipping or tube feeding through nasounal tube, pharyngostomy, or unistomy. A combination of two methods also may be prescribed. Traditionally, in abdominal surgery, total parenteral nutrition was the main method of postoperative nutritional support. It was based on the belief that fasting reduces the frequency of surgical complications. However, in recent years, more and more studies have recommended the implementation of enteral nutrition in early postoperative period, considering this method more safer and more cost-effectiveness than to comparing to parenteral nutrition. Enteral nutrition maintains erythrocytes viability, improves gastrointestinal motility, and provides intestinal wall barrier function. All this reduces the frequency of infections, complications, and the average length of hospital stay. The possibility of early oral feeding after abdominal surgery was studied in colorectal surgery, in the surgery of liver, pancreas, and stomach, including gastrectomy with high esophageal anastomosis. The research results demonstrate that early oral feeding is not only safe, but also improves results of treatment, accelerates recovery after surgery, and increases patients' comfort. In esophageal surgery, enteral nutrition is recognized as the optimal way of feeding. It's also part of the ERAS community recommendations. In most cases, tube feeding through nasounal tube or unistomy is prescribed. But ERAS community concludes that the ideal route of administration of enteral nutrition in the early postoperative period remains unclear, and currently no recommendations can be given. 44% of patients after unistomy have complications like cellulite inflammation around the tube, parastomach leakage, tube transposition, and malabsorption. In addition, in 7% of patients, the unistomy tube causes acute intestinal obstruction. Using nasounal tube also leads to complications like displacement or obstruction of the tube and microaspiration of hymas that leads to pneumonia. Methods that avoid oral feeding are used to prevent the anastomic leak. Studies where early oral feeding was used after minimally invasive esophagectomies were made and showed positive results. The duration of hospitalization was reduced from 10 to 8 days, and the quality of life after surgery was significantly improved, and the nutrition cost was reduced. But why oral feeding and why oral food intake is so important? The answer lies in the physiology of digestion. There are two types of food saturation: sensory and metabolic. Sensory saturation is rapid, occurs at the time of eating because of irritation of the receptors that are located in the oral cavity, esophagus, and stomach by food. Then different impulses from these receptors go to the neurons of hypothalamus. And as a result, anoxygenic hormones are released and food motivation disappears, and the desire to eat also disappears. Evolutionarily, the oral food intake gives the body confidence that the supply of nutrients will be replenished and the usage of available resources is safe. The metabolic phase of saturation includes the processing of ingested food with digestive enzymes, its absorption into the blood flow, and the replenishment of spent resources. As the result of saturation, hunger ceases, and in state of satiety, the body is able to cancel the dominant search and supply and search and food supply, and begins to perform other tasks like physical activity and recovery after surgery. So the aim of our research was to improve the results of treatment after esophagectomy with gastric tube reconstruction by choosing a method of nutritional support in the post-operative period. And from January 2016 to December 2020, a prospective randomized study was performed at the Vishnevsky National Research Medical Center in Moscow, Russia. The study included patients with malignant tumors of esophagus, benign strictures of esophagus, and achalasia, who underwent transthoracic or transhiatal esophagectomy with immediate gastric tube reconstruction. Inclusion criteria were the approval of surgeon to early oral feeding based on visual assessment of the viability of the conduit and stump of the esophagus, the absence of technical defects in the formation of anastomosis, and low risk of malnutrition. Exclusion criteria were aspiration detected on the first postoperative day during X-ray control of the esophagogastroanastomosis, the severity of patient's condition, and the postoperative complication that didn't allow X-ray control of the cervical anastomosis on the first postoperative day. The inability of patients to fulfill the doctor's recommendations due to initial cognitive impairment and malnutrition. Depending on the type of nutritional support in the post-operative period, patients were divided into two groups: the main one with early oral feeding from the first post-operative day, and the control group with total parenteral nutrition from the first post-operative day and oral feeding from the fifth post-operative day. There were no significant difference between the groups. All the patients before hospitalization were consulted by a multidisciplinary team consisting of anesthesiologist, resuscitator, surgeon, and cardiologist. And individual preoperative examination plans were performed. According to the protocol of patients management based on ERAS recommendations, the prevention of thromboembolic complications was started by administrating of low molecular heparin in 12 hours before surgery. Food intake was stopped in 6 hours before surgery. Premedication and mechanical bowel preparations wasn't prescribed. In 30 minutes before surgery, antibiotic prophylaxis was performed by ampicillin sulbactam and was repeated in 4 hours during surgery. In the operating room, an epidural catheter was installed on thoracic level. After fast sequential induction into anesthesia, central venous catheter was placed and catheterization of radial artery was performed. Prevention of post-operative nausea and vomiting was made by administration of 4 milligrams of dexamethasone before induction into anesthesia and 4 milligrams of ondansetron in 30 minutes until the end of the operation. After the formation of cervical anastomosis, if the gastric tube and esophageal stump visually were viable, there were no technical errors in the formation of the anastomosis. The surgeon decided on the possibility of early oral feeding. In case of positive decision, the patients were randomized into two groups using online randomizator. At the end of the operation, immediate tracheal extubation was performed. Patients were transported to ICU, where monitoring of vital functions, infusion therapy, prevention of thromboembolic complications, and infection complications were continued. In 2 hours after the intervention, patients were verticalized in the ICU unit. And on the morning of the first post-operative day, patients were transferred to the surgical department. Radiography with the oral intake of water-soluble contrasts was performed. On the slide, you can see the patient's management protocols. In early oral feeding group, patients permitted drinking water from the first post-operative day, sipping from second post-operative day. Smooth food intake was allowed from the fourth day. The discharge was possible from the 6th day. No parenteral nutrition was prescribed. In the second group, with traditional protocol, total parenteral nutrition was appointed for 5 post-operative days with the nip-by-mouth regime. On the 5th day, drinking was allowed and a smooth food intake was permitted from the 7th day. The discharge was possible from the 8th day. Comparing the results of treatment of the main and control groups, we didn't find a significant difference in the number of patients with post-operative complications. The main fear while prescribing early oral feeding was an increased risk of an stomach leak. And in each group, there was one case of an stomach insufficiency in the post-operative period. In the early oral feeding group, an stomach leak occurred at the 6th post-operative day. The patient experienced repeated vomit because of hypertensive crisis, after which the leak was found. During the control radiography of the esophagus on the 1st, 3rd, and 5th post-operative days, the patient's anastomosis was good. Then total parenteral nutrition was prescribed and the fistula closed, and the patient was discharged on the 27th post-operative day. And in the early oral feeding group, there was a statistically significant earlier discharge of gases and the appearance of stool. Early activization and nutrition, absence of ileus allowed us to note a tendency to decrease post-operative length of stay from 9 to 8 days. In order to assess the effectiveness of early rehabilitation in 6 minutes, a 6-minute walking test was performed. Initially, the distance that passed patients in the early oral feeding group and in control group did differ significantly. At the third post-operative day, the test results in patients of both groups were worse than initial ones, but the difference between the groups remained insignificant. But on the 6th post-operative day, patients who received early oral feeding tolerated physical activity significantly better. Hydrothorax that required a single puncture was the most common complication in both groups. The type of post-operative complication also didn't differ significantly. During the study, the anthropometric and laboratory parameters of nutritional status were evaluated. The main interest was the change of proteins concentration in plasma. Albumin, transferrin, and prealbumin have different half-lives, like 28 and 2 days. Prealbumin has the shortest half-life, so its concentration is the best reflection of effectiveness of nutritional support. Its level significantly decreased by third quarter in the early oral feeding group due to the inability to fulfill daily calorie intake in the first days of the surgery. At 6th post-operative day, the amount of prealbumin leveled in both groups, and no other significant difference between the groups were found. Based on this research, an algorithm for the selection of post-operative nutritional support was created. This algorithm included also patients with high risk of preoperative malnutrition. If patient has a low risk of malnutrition in post-operative period with the visual viability of conduit and stump of the esophagus, then early oral feeding is performed. In case of unsatisfactory blood supply of the transplant, patients are prescribed total parenteral nutrition according to the classical scheme. In the presence of initial malnutrition or high risk of its development in the post-operative period, and with the initial viability of transplant patients are given a combined diet, like early oral feeding with the supplement parenteral nutrition, in order to make up for the calorie deficit that occurs in the beginning of the oral nutrition. If the viability of the conduit and the quality of anastomosis do not suit the operator, then combined tube feeding and parenteral nutrition are prescribed. In conclusion, I'd like to say that the early oral feeding doesn't increase the frequency of surgical complications, improves the quality of post-operative recovery, increases the patient's comfort, avoids specific complications associated with parenteral nutrition and tube feeding. And early oral feeding is safe and effective in case of high quality of the surgical technique, close interdisciplinary interactions, and patients' involvement in the treatment process. Thank you for your attention.
Thank you.